And we're going to broadcast. Kendall, whenever you're ready.
Go ahead and start.
Yes.
Okay. Hello, and thank you for joining us for this week's webinar. Our webinar this week is on the role of telemedicine in delivering palliative care to patients and families during the COVID-19 pandemic. This webinar is being recorded and will be available shortly after its completion. My name is Hiba Osman, and I'm a board member of the International Association for Hospice and Palliative Care, and I'll be moderating today's webinar. This webinar is number 10 of a series of 13 and a project on palliative care and COVID-19 developed jointly by the International Association for Hospice and Palliative Care, the International Children's Palliative Care Network, Palliative Care and Humanitarian Aid Situations and Emergencies, PALCHASE, and the World Hospice Palliative Care Alliance. The objective of the series is to provide globally relevant information and guidance to civil societies and UN organizations, policymakers, administrators, and healthcare providers on palliative care in the context of the COVID-19 pandemic. The webinars are accompanied by briefing notes written by experts from around the world. The briefing notes are available in the globalpalliativecare.org website, and the webinars are uploaded to the WHPCA website. We'd like to thank the organizers for this series for creating a platform that's encouraged the sharing of information and ideas at a time when we needed it most. We're very grateful to all the contributors to the series and to today's presenters, as well as the contributors to the associated briefing note. Thank you for agreeing to participate today and for taking the time. This webinar will feature 3 20-minute presentations with time at the end for questions and answers. You can submit your questions in the chat box. Please submit them to everyone. Kate Franklin will be collating the questions and presenting them to the presenters at the end. I would also like to ask the presenters not to respond directly to questions in the chat box, but reserve the questions and answers to the end of the session. Next slide, please. Next slide, Stephen. In today's webinar, we're going to dive deep into telemedicine. Although this is a tool that's been used in the past, this pandemic has catapulted it to the forefront. We've had rapid growth of telehealth services around the globe out of necessity, and we're hoping to cover a lot of ground today. We'd like to start with some basic definitions and concepts and guidelines so that we're all speaking the same language and all on the same page. Then we're going to follow it up with a SWOT analysis on telemedicine based on the regional experience in Latin America. And finally, we'll be sharing the experience of one organization providing home-based palliative care. And we have the privilege of having a caregiver also share her experience getting this kind of care. Next slide, please. Next, please. This is the associated briefing note, and you can find it on globalpalliativecare.org. In addition to the presenters today, we had 2 other physicians that I will present later in the presentation who contributed to both the briefing note and today's webinar. Next slide, please. The presenters have no conflicts of interest. And this first presentation will be by Matthew Alsop, a University Academic Fellow at the University of Leeds, and Yves Namisango, the Program and Research Manager at the African Palliative Care Association in Kampala, Uganda. Please go ahead.
Great, thanks very much, Hiba. So I'm going to present the first half of this presentation and provide some background and context to telemedicine and the current state of the evidence supporting its use. And then Eve's going to take over for the second half, describing how telemedicine has been used to date in palliative care, including how it's been used in response to COVID-19 in recent months. So in doing some reading for this presentation, I discovered actually that the use of telephones or telecommunications more broadly in health use, even thought that the first words uttered by Alexander Graham Bell on the telephone back in 1876, he first said, "Mr. Watson, come here, I want you." And it's thought that that was because Bell had just knocked over the battery, powering the transmitter, and had spilled sulfuric acid on his clothes. So actually he was calling his assistant Watson for first aid. So telemedicine's existed since the invention of the telephone, really. And there's a nice article by Aronson. It's quite a detailed article outlining this earlier history of telemedicine. And this is even back in 1977, and it describes correspondence in The Lancet as early as 1878, so only 2 years after Bell's invention of the telephone. And there were some physicians describing the possible use of the telephone in place of the stethoscope to study muscle contractions at a distance. So I think health professionals have always been quick to see the possibilities of communications technology for health. So that was quite interesting background reading. But over time, and with the increasing availability of different types of, telephone and other communications technology, there's also been multiple variations of labels and terms that include tele, describing different ways that these technologies can be used in healthcare. But I thought it would be helpful to start with a broad definition provided by the WHO, the World Health Organization, of telemedicine as the provision of healthcare services at a distance. So here it's seen distance as a critical factor, and it's very much focused on the provision of patient care and delivery of services as a means of overcoming geographical barriers. And we'll get into the specifics of how that might occur, but I just wanted to differentiate telemedicine from, for example, telehealth, which is a broader overarching term that can include activities such as the provision of education resources and administrative functions as well. And then we have telecare, which is a specific application for supporting people to live independently. And that can be using remote monitoring that might trigger alerts, for example, in the event of a person having a fall. And then there's also mHealth, or mobile health. And this is a more specific way to utilize mobile technology, such as mobile phones or mobile tablets, to achieve improved health goals. And while these different definitions do exist, it's worth noting that the WHO is moving away from these specific terms, such as mHealth, to a much broader use of the term digital health to encompass all of these different approaches. Next slide, please. And there are different ways to classify approaches to telemedicine. So one way is by thinking about the nature of interaction between the users. And these can include both patients or caregivers alongside healthcare providers. So different examples might include, so at the top there's clinician to clinician. So this might be peer or expert consultation. So a nice example is Project Echo. And this is a knowledge sharing network approach, and it's done in what's called a hub and spoke model. So you normally have a hub that's usually an expert team who use video conferencing to conduct virtual meetings with multiple healthcare providers. They might be primary care clinicians or generalists. And then sessions are led by the expert teams and can involve routine monitoring sessions, including discussions of case presentations and lectures. And this way of using video conferencing has been really popular globally across a range of disease areas, and also it's becoming increasingly popular in palliative care too. You can also look and see telemedicine as supporting communication between clinician and the patient. So examples here might be remote patient monitoring, so during home-based care, or for example, video consultation. So this is where you'd put Skype or Zoom calls between a health professional and a patient. And then there's also patient to mHealth. So this is specifically on a mobile phone. It's a mobile phone based intervention approach that might have a patient using a mobile phone to support, for example, health education or physical activity monitoring. Next slide, please. And then another way to consider the different approaches to telemedicine is thinking about the flow of data. So this can occur in asynchronous telemedicine systems that involve the transmission of data. So this might be routine outcomes data, medical images, for example, that are sent to a patient's record that a health provider can review at a suitable time. And this system is often used in situations that don't require simultaneous attention of healthcare providers. And it's commonly used in fields such as radiology, pathology, and dermatology. And then there's the interactive telemedicine system, which is also known as synchronous video conferencing, which can provide two-way real-time interactions between patients and healthcare providers through telecommunications technology, where there's a very good network infrastructure. And just thinking about the key components or requirements to develop a telemedicine intervention, it would typically include a personal device that will be with the patient or caregiver, whether that's a personal mobile phone or other device. And this could be connected to peripheral devices such as sensors if required. And as an option, if you're using sensors or require continual analysis of data being shared by patients, you may need a server to store and process data. So for example, if you've got, if you have a patient with cancer using a mobile phone to report symptoms or toxicity while they're based in the community at home, that might be a potential model where that will be helpful. So the data a patient reports might need to be analysed to generate alerts if they're needed. And it may also be possible to incorporate those data from the patient into their electronic medical record. So this would all require a server to aggregate, analyse, and help link data. But you wouldn't need this, for example, with a consultation held by Skype. And then the third component is the health service centre. So this is where the health professional is based, and often where access and interaction with the patient's digital health information is overseen. Next slide, please. And for telemedicine, there have been and continue to be factors contributing to its growth. So in the context of particularly high and some middle income countries, there are a number of factors that are driving the growth of telemedicine. So one key driver is the pervasive and wide availability of devices that can be used for telemedicine. There are increasing numbers of people who own mobile phones, including smartphones, and this provides an ever-advancing infrastructure that can be used. And this isn't isolated to high and middle income settings. There's recent data that suggests a median of 37% of people own smartphones in emerging markets. There's also escalating patient and caregiver demand for virtually delivered care with recognised benefits, including the convenience, the cost savings, and then also reductions in travel. And continuous advancement of electronic health records and clinical decision support systems too. So this creates the ability to integrate data from a patient's mobile device, such as patient-reported outcomes data, into their electronic health record, which can be presented alongside clinical data to inform decision-making. And as mentioned, most of these drivers relate to high middle-income settings, but in low-income settings, low-resource settings too, factors such as the predominance of health professionals in urban settings and increasing use and availability of mobile phones may also be driving exploration of telemedicine approaches in these settings too. Next slide, please. And for the World Health Organization too, telemedicine is seen as an approach that can support health systems strengthening. So in 2019, the first recommendations were published by the WHO, and part of their purpose is to provide recommendations and implementation considerations to inform digital health approaches. And within the guidelines, there's a detailed overview of the state evidence, factors to consider for telemedicine approaches, covering both provider to provider approaches and then also provider to patient approaches. Next slide, please. And within the guidance for different applications of digital health, there's an overview of the effectiveness, acceptability, feasibility, and then the gender equality and human rights considerations. And for telemedicine, the evidence is drawn from across all health disciplines. And thinking about effectiveness, for provider to patient telemedicine approaches, there's evidence that it can improve some outcomes, such as fewer unnecessary clinical visits and reduce mortality among individuals with heart-related conditions, but it may make little or no difference on other outcomes, such as hospital admissions for health-related conditions or older adults receiving home-based care. And for provider-to-provider approaches, telemedicine may improve health worker performance and reduce the time for clients to receive appropriate care or follow-up, but the intervention may make little or no difference to other health status and well-being outcomes, such as clinical improvements in individuals. In terms of acceptability, broadly telemedicine approaches are considered to be acceptable, but there are ongoing considerations, such as which cases still warrant face-to-face contact, and some of those challenges will be picked up by Louisa in her presentation. And similarly for feasibility, the guidelines also highlight general challenges that are faced in delivering telemedicine approaches, including network coverage, access to electricity, the usability of a device, sustaining training. Again, these factors will be picked up in more detail in Louisa's presentation. The WHO guidelines also highlight the positive impact of telemedicine approaches on health services, such as facilitating access to health services, particularly for individuals who speak minority languages, and also enables health workers to facilitate access to higher level care on behalf of their clients. So it may reduce the burden of travel, particularly for people with caring or work responsibilities and those living far from health facilities. However, access to telemedicine services may be difficult for other groups. So for example, people with hearing impairments or poor digital literacy. Next slide, please. And we know there's demand for this type of approach in low middle income settings. I wanted to highlight some findings from a recent study that Eve and I completed in Nigeria, Uganda and Zimbabwe. And we sought to explore how data and information needs across palliative care services might be supported by digital technologies. And broadly across patients, caregivers, health professionals and policymakers, there was support for digital health approaches. And that can be seen down the left in terms of reported attributes of digital technologies. So the identified attributes included their availability in the community, user friendliness, and for some they were seen as affordable, and then benefits of the at the health service level of avoidance of data loss through recording and storing data. And key concerns existed across all stakeholder groups through ensuring the privacy, confidentiality, security of data. They were found through all stakeholder groups. But we also identified requirements for what digital technologies might support for palliative care in the 3 sub-Saharan African countries that were involved in this study. So I'll just show those in a bit more detail, please, on the next slide. Yeah. So if you could just click one more time, please, it'll expand on those.
Sorry, Matthew, it's not working.
That's perfect. That's great. Thank you. Okay, so when looking across the different stakeholder groups, the preferences for use of digital technologies within palliative care services is really for dynamic approaches that are reliant on digital technologies being used to ensure direct support for patients. So, for example, through patient self-management guidance, alongside using patient data to inform service delivery and improvements at the health professional level. And then policymakers too saw value in patient and service level data to inform their decision making so that it can be guided by data. So this highlights the demand for telemedicine and digital health approaches in the delivery of palliative care in participating countries, and that their deployment shouldn't be reserved for high and middle income settings. At this point, I'll hand over to Eve, who's going to outline how telemedicine has been used in palliative care and has been part of supporting a response to COVID as part of palliative care services.
Eve, you're unmuted now. Eve, can you go ahead and start your presentation? Having a little technical difficulty here.
I can't hear anything. I'll just confirm if you can hear me.
Yes. Yes, we can hear you.
Okay, so I'll transition through telemedicine approaches to deployment in palliative care, and I'll highlight a couple of relevant examples. We have home telemonitoring, involves use computer software to respond to patient clinical symptoms or signs from the patient's home. And we have the example of telephone advice line, which can be used as an intervention, taking a reactive or proactive approach to using telephone services. And then online or video conferencing platforms, largely to facilitate education for patients and their carers. And of recent, the very common video conferencing approach to supporting education and networking opportunities for health professionals, most importantly in the context of the COVID-19 epidemic, where the epidemic is evolving very fast and people need to, And I'll continue to say that these interventions have led to improvements in symptom assessment, symptom management, comfort with care, as well as patient and family satisfaction with care. And telemedicine has also been used for communication, counseling, disease monitoring, and the intervention has been associated with reductions in mortality, hospital admissions, and overall improvements in quality of life. Next slide, please. Wow. So now we are looking at the role of telemedicine approaches, most especially in the response to the COVID-19 pandemic, and why it's important to consider telemedicine options. I'll make reference to the recent WHO survey on the disruption of services for the prevention and treatment of non-communicable diseases. And the survey was responded to by 38 of the 53 member states, and 74% of the respondents reported a disruption in NCD services. Most importantly, 47% of the countries reported disruption in palliative care services, and the disruption was either completely or partial. And in response to this concern, countries in the WHO European region are already putting in place a range of interventions to mitigate this interruption. And one of the interventions is the use of telemedicine and digital technologies. In fact, in a quarter of the countries, they are already looking at novel supply chains to ensure continuity in the access to medicines and essential supplies for non-communicable diseases. And there is also an increase in the use of video communication between patients and families, the use of iPads to allow outpatient palliative care clinicians to conduct video visits with their patients who may be hospitalized, and then to allow for virtual visits for both adult and pediatric patients, and the use of e-based self-support approaches to delivering routine components of palliative care, such as spiritual and existential well-being, as well as grief and bereavement support for patients at the end of life, some of whom may be in isolation units. Next slide, please. So we have a couple of recommendations from the research on the use of telemedicine in the context of the COVID-19 pandemic. And we should all be mindful that as palliative care healthcare providers, there is a risk of getting infected or some of our colleagues getting infected and there is a risk of colleagues having to go in quarantine. Therefore, it's important to have groups of palliative care providers who can come together to address the cross-coverage needs and then the fluctuations in the workload to avoid the disruption in service delivery. And we need to develop a workforce and script to perform virtual conversations, as face-to-face conversations are becoming less popular due to the public health preventive measures, and to identify novel mechanisms to complete advanced care directives virtually, most especially in the community settings, and to maximize the use of telemedicine, both for efficiency and also to reduce on the risk of infection transmission, and also to enable video calling to connect patients and their family members. And the separation could be due to travel or changes in visitor policies. And of recent, separation is a big crisis that we need to respond to and address in palliative care. And part of the plans to support the rapid de-escalation and triaging of patients, most especially in community-based palliative care services, we should be looking into the use of telephone-based triage, and that can be very useful for non-urgent home consultations. Next slide, please. And we have a couple of recommendations largely drawn from our recent survey on the preparedness for COVID-19. And we are emphasizing the use of telemedicine in the training of healthcare workers. The epidemic is evolving rapidly and people need to be on top of cutting-edge evidence in patient care, self-care, and personal protection. So technology can be very useful. And then also the use of technology to support healthcare workers' self-care, and empowering them with skills and ways of handling and managing burnout, and also novel ways to sustain uninterrupted supply chains for essential medicines and supplies. We have our Africanized motorcycles or border borders, which can support deliveries, and some African countries are already using drones. And then the need to support access to patient-level data to inform healthcare prioritization. And this is very useful for those who need to plan for home and community-based visits. And most importantly, for Africa, we need to look into technology options that can support our patients in rural settings. We know that over 90% of our patients are in rural settings. So we need devices that can use solar power, which is a natural gift to Africa, and multi-user devices, which can serve large populations. And we also need to consider task shifting some of the roles. For example, self-care is a role that we could try to task shift if we empower patients and care providers to use technology and do some self-monitoring.
Thank you, Eve and Matthew. Please, for our audience, I'd like to remind you to use the chat box for your questions, which will be addressed at the end of the session. Our next speaker is Dr. Luisa Rodriguez Campos. She's assistant professor at the Department of Pain and Palliative Medicine at the Universidad de La Sabana in Bogota, Colombia. She is presenting on behalf of the group in Latin America that included Dr. Gabriela Piriz Alvarez from Uruguay and Dr. Nicolas Garrigue from Buenos Aires. Thank you, Luisa.
Thank you, Hibab, for that presentation. And I will resume a little bit of what Matthew and Eve just said. And that is that in the face of the COVID-19 pandemic, governments throughout the world proactively took multiple measures to slow down disease progression and showing that vulnerability to all health systems around the globe. And for sure, to ensure continued health services, telemedicine became rapidly part of everyone's reality. And so COVID-19 transformed the telemedicine landscape with breathtaking speed and expanded its use beyond what we anticipated, becoming the primary strategy to confront social distancing and quarantine measures quarantine measures dictated to protect the population. So this situation is in contrast to a long history of a slow adoption of telemedicine, as Matthew just said in his presentation. And specifically in the field of palliative care, in the pre-COVID times, we were already facing important challenges that are inherent to our specialty, and we were adopting telemedicine to bring care at homes for seriously ill patients and their families. And these difficulties are well known to all of us, such as patients having difficulty accessing a specialized center due to geographic barriers, or low staffing at regions, or high burden of traveling to clinics for patients who were symptomatic or had a functional limitation, or circumstances such as climatological changes or political adversities that impede patients to access to palliative care services. So with the emergence of COVID-19, the telemedicine became more visible beyond what we anticipated before, and became an important level of care as any other within the health system that allow us to deliver care to those in need. So this brings us here to the perfect time to analyze telemedicine, as telemedicine is in an important moment to in the spotlight. So acknowledging telemedicine as a tool that has some strength, some weakness, some opportunities, but also some threats, and recognizing them will be of great utility to promote careful planning and telemedicine, and see telemedicine as a potential tool for the delivery of health services in palliative care now and the future to come. So next slide, please. So during the COVID-19 pandemic, telemedicine has been embraced as a necessary means to sustain health systems, as Eve said, and facilitate first contact with patients that were facing a need for a diagnosis, but also has been a tool for complementing face-to-face encounters or follow-ups of patients already known to the providers. So it has demonstrated a critical role in expanding healthcare capacity, and this major capacity for remote assistance has provided an opportunity for health providers to have protected times for clinical encounters to provide care through telemedicine from their homes or from their clinics, as the priority became supporting patients at home cares rather than the traditional focus for inpatient activities. Also, this tool has also facilitated interaction with patients and caregivers, because it has been rapidly available for everyone. It has demonstrated to be a way to help resolve important issues related to symptom management, comfort care, and patient education, as Eve mentioned before. And this has helped decrease perception of burden for caregivers, but also has reduced the need for home visits and the use of emergency services for patients at home. Next slide, please. So telemedicine has been used as a tool to facilitate communication between healthcare teams and help coordinate care, and has probably be a space for encounters with other medical specialties that were not physically available at clinics, and help to agree in goals of care, and has also proven to be useful as a space for interdisciplinary meetings and family meetings across different specialties, and also has allowed us to keep on incorporating holistic vision of care, although we have to recognize that socioeconomic, spiritual, and psychological factors might pose challenges in communication during telephone or video calling, but has been seen as an opportunity to assess resources available and risk for patients at his or her usual place of care. And this has been an important thing at this time when we have seen greater social and psychological vulnerability at homes like unemployment and domestic violence. So another great opportunity has emerged with telemedicine, as it enables us to follow on grieving family members at times when funerals are different and the risk of complicated grief might increase. Telemedicine has also provided spaces to share experience with healthcare teams in times of pandemic worldwide, and help develop professional networks and promote spaces for national and international cooperation, especially for knowledge transfer. And it also allowed us to recognize the value of clinician encounters that help analyze complex cases raised by professionals who work alone in remote regions, which facilitated problem solving, educational on specific topics, and help them feel the support of colleagues, like, for example, what ECHO project is doing in some countries in Latin America. And telemedicine has been a strategy to reduce the perception of isolation for either patients, caregiver, and healthcare workers, and has created spaces for online support between caregivers, which has been also a great opportunity. Next slide, please. So practicing telemedicine poses also several challenges to clinicians, and as it has been an evolving tool. And initially, most started as improvised provision of telemedicine with no standardization in encounters in places that were not conditioned for the provision of the service, and with limited access to medical records, and also with inconsistent record keeping, and with no protocols rather for providers, neither for patients or caregivers. And we realized that the use of platforms needed some kind of training, even for healthcare providers, and also for patients and caregivers. And we need to recognize that there are some age-related barriers for engaging in telemedicine for older adults who have less experience in emerging technologies. So other barriers that must be overcome are those related to the electronic prescription, especially for controlled substances and for home delivery of medication, because without these services, going out to pharmacies poses the patient and family member to an unnecessary risk. So there is a need for consistency in the supply chain mechanism to ensure access to medicines at home, as Eve mentioned before. And there's also a need for additional education, as that might be an additional risk about electronic prescription because they might be incorrectly interpreted either by patient or caregiver. Next slide. So there is still a population that has not been able to receive health services during this pandemic, showing inequitable access to health services via telemedicine, specifically because technology and connectivity are not universally available or affordable. Or when they are available, problems arise, such as connectivity problems, video problems, or sound problems during clinical encounters. But there is limited technical support for providers and patients that prevents the meeting from taking place. Next slide, please. Next slide. And this brings us to another important issue, and it is that telemedicine has also challenged the physician-patient relationship in unpredictable ways. And we need to reflect what it means for a doctor to see a patient and vice versa, and how to obtain the benefit of an in-person encounter in building trust and rapport with telemedicine. So the challenge need to be addressed with this model of care is to find balance between humanization, as it is essential for effective patient-centered care. but with humanization is also needed for providers, as we have seen work overload in relation of patient and family expectations for attention 24/7. And technology also poses limitations for an adequate assessment in the clinical encounters, as physical examination relies only on partial inspection that could lead to underestimation or misinterpretation of disease. So aligned expectation and scope of the virtual encounters are essential, and there are some things that need to be addressed the traditional way. But this also brings an opportunity to incorporate artificial intelligence devices to support the clinical encounters, such as electronic stethoscopes, electronic blood pressures, pulse oximeters, and even ultrasonography. It's possible to achieve if these peripheral devices can be incorporated in the clinical encounters. And virtual spaces and encounters bring us important issues that are not new in the era of social media, but for healthcare poses a specific challenge, and that is that there is a need to protect the security and the integrity of patient information with the technology available, which also lead us to the field that is need to be expanded and explored, and that is what are the medical and legal implications for healthcare providers practicing telemedicine. So there is a need for construction of the ethical and legal framework for telemedicine. Next slide. So the changes initially instigated by the COVID-19 pandemic have altered the position of telemedicine in all healthcare systems. So telemedicine is here to stay and is going to stay for a long time. And telemedicine has also already proved to be an invaluable tool, not only to divert a volume of patients from the emergency rooms, but also to transform the work practices of thousands of providers across multiple specialties and including palliative care. And although initially started as provisional service, as in provisional services, you can pass to the next slide, please. Transition is needed to a more organized form where technology is really a component of the overall equation that telemedicine brings. So a roadmap for effective implementation must start with the provision of technology and connectivity, but telemedicine planners should concentrate on organizational changes and the mechanisms of delivery telemedicine services. So policymakers have the tasks to capitalize the potential of telemedicine seen during this pandemic and promote its development during normal times. So legislation and regulation is needed under principles such as inequality, equality, universality, efficiency, confidentiality, and incorporating telemedicine into healthcare plans for reimbursement. And this might be an opportunity to start promoting undergraduate curriculum to incorporate training in telemedicine skills, as quality of care is needed to improve patient-centered outcomes. Next slide, please. But attention also must be paid, not to overuse this tool, as boundaries are needed for proper use, and telemedicine must be seen as a complementary level of care within the health systems. And both the patients and healthcare professionals require a better understanding of the scope of telemedicine in order to provide quality of care. So research on the efficiency and effectiveness of telemedicine must be a priority. Next slide. And to bring things to a close, there is definitely a need for innovation in models of care with telemedicine. And for an effective implementation, questions must be answered like if telemedicine works, how telemedicine works, when and where telemedicine works best. And there is a need for measured telemedicine outcomes in terms of access to care, in terms of cost for the health system, and in terms of cost effectiveness, but also in terms of experience for patients and for clinicians. But for now, there's no one-fit-all model for telemedicine, and every model until now constructed during this time in pandemic need to be integrated into the existing healthcare system. So it is time to be open and receptive to changes and embrace lessons from the present to generate networks and openness to knowledge and cooperation to strengthen health systems, like Matthew said at the beginning, around the world, and provide quality of care for those in need. So I really appreciate your attention today and would like to thank again to Gabriela Piris and Nicolas Garregue that helped with the construction of this content. And back to you, Hibab.
Thank you very much, Louisa. Our final presentation is by Dr. Aline Zachem, who's the Medical Director of Balsam, the Lebanese Center for Palliative Care, as well as Rana Aid, a patient caregiver that received Balsam's caregiving services. They will be presenting on the activities of one organization doing home-based palliative care. Thanks, Aline.
Thank you, Hiba. Good morning, everybody, or good afternoon. It depends where you are on the globe. So my experience today, I'm going to be talking a bit about the experience of Balsam, which is the Lebanese Center for Palliative Care that provides palliative care to patients residing in Beirut areas and the suburbs of Beirut. So usually patients who are away from Beirut, we enroll them under the distance support program. Next slide, please. So the distance support program turned out as an utmost necessity in order to address the concerns and the symptoms of many patients who reached out to us and who needed our support. However, because of the traffic and the distance, we were not able to provide the support of urgent visits by our nurses. So we created this distance support program that started in 2015, whereby patients would have access to our medical care 24/7 to a nurse, usually by telemedicine. Whatever the patient has tools as telemedicine, whether it was phone calls, video calls, WhatsApp calls, whatever the patient has or the caregiver has available with them. Ideally, to be enrolled with this distance support program, we would love to have a one-time visit whereby the nurse would and or the physician will visit the patient at least once upon admission into our service, so we can form this bond with the patient and that we can establish the trust so we are able to manage the patients accordingly. Next slide, please. And we looked at our data to see how things evolved and what was the feedback of our patients, especially that it was something that we started and we were not sure how patients in our region, in our area, would appreciate the telemedicine provided care. So this is a study that was recently published in the Journal of Palliative Medicine about our experience with palliative care via telemedicine, whereby it's a qualitative study that interviewed the caregiver and the provider in order to see what are their perceptions and to analyze how the caregiver and the provider could assess the care we provided via telemedicine. Next slide, please. And it was kind of universal and uniform among all participants and caregivers that they valued a lot the support program using telemedicine. The caregivers mentioned upon multiple interviews, and many caregivers mentioned that they appreciated the information that's always available, the guidance and the supervised guidance where they would appreciate that the caregiver the professional is with them over the phone or guiding them what to do, the emotional support too, and most importantly, the easy access to skilled provider by phone during a time of high anxiety and uncertainty. And by easy access, we really mean the 24/7 availability of the team to help with the symptoms of the patients. Next slide. And then March 11, WHO, the World Health Organization, declared that COVID-19 is a pandemic. And this is where we had to take actions in order to accommodate this new pandemic that was hitting our country. So as of the next day, many decisions were taken in our organization in order to make sure that you are protecting both our patients and the nurses and the doctors. And this is where we decided to shift to the distance support program, which is already a structure that you already had. And that was actually kind of an advantage to us in the middle of the crisis, when many organizations would need to start with new policies and figure out new tools and a different workflow to do the job, whereas we decided we already have the structure and we will move all our patients to what we call distance support program, which means we're gonna continue to take care of the patients who are admitted under our care. However, only by doing the distance support by the phone and all the means of telemedicine. However, it's the right of our patients to be pain-free, to be symptomatic-free, and to have a preserved dignity. Therefore, emergency visits were allowed, and only whenever it is emergency visit. So it's no longer the regular visit, but the nurse would go visit the patient if it is deemed to be an emergency condition that required the physical presence of the team at the patient's place. Of course, the adequate personal protective equipment were very important, and the team were instructed about the required PPEs whenever they enter a patient's home, and the adequate infection control practices required to protect everybody from the infection. Keep in mind, it was the concern even of the families of the patients. Sometimes they don't want us to visit them, and if there was any concern from our team to visit the patient, but with adequate infection control practices and education, the team felt comfortable. So we can say that it was more like an easy transition to a different modality of care for our team. Next slide, please. Many challenges, of course. We're not gonna pretend it was that easy. And in our country, we were one of the very few countries that imposed strict lockdown and very strict rules very early on in the pandemic. So a few days later, the whole country was under lockdown. And in addition to that, there was a restriction for vehicles. So according to the plate number, so if the last digit of your plate number was an odd number, you were allowed to drive your car on Monday, Wednesday, Friday. If the last digit is an even number, you can drive your car on Tuesday, Thursday, Saturday. And on Sunday, no one was allowed to drive their car. The only exceptions for the people in the medical care system, so if a nurse, a physician, or people who work at the hospital, they can drive their cars if they have their hospital ID. For healthcare workers and other organizations, they would need the card from their respective syndicate or a letter of employment from the institution where they're working to justify that they are driving their car for medical purposes. However, the patients did not have this exception. Another major challenge was finding somebody who would provide the same services like before. Many institutions would refuse maybe to go and to withdraw blood for the patients at home or to do imaging. So it became difficult for us to order the chest x-ray, for example, or the blood tests that usually were done at the patient's place. Another rule we had so the government allowed us finally to do prescription by WhatsApp. So we were allowed to write prescription for medications on a regular prescription and take a screenshot and send it by WhatsApp for the patient, who can provide it to the pharmacy to get the medication. And the same thing would apply to any blood test or imaging that we need to order. Not only the COVID-19 challenges and the lockdown and the rules that we had, we're a country that's struggling with an economic crisis like the first time ever. And plus, we're sorry to say, we don't have electricity 24/7. So we can get electricity power cut at any time. And this had increased in frequency with all the crises. And in addition to that, we have to address that we don't have the Wi-Fi signal that's always excellent. It might cut off many times. The bands might not be perfect. You might not find the 4G all the time available. Next slide, please. Despite all the challenges and all the crises, if we look at the advantages and the good thing that patients can tell us about this experience and what balsam we have experienced in that, is that the accessibility to patient care was available 24/7 during all these stressful conditions, with either the phone calls, the video call, the WhatsApp call, the voice notes. Many times diagnosis could be made just by a video call. Like if we want to decide if a patient is terminal, we ask the family to take us a video call and to show us what's going on. Sometimes guidance was done by video call, even voice notes were very important. And really the patients found creative idea, and people who were not used to use the smartphone or the application that are available learn to use them under these conditions in order to provide us with the best accurate information up to their knowledge. Moreover, the load of patient per nurse has increased since the telemedicine was very effective care for us, and it required less time than doing the home visits. So the number of patients the nurse was taking care of could increase, and the nurses would not feel overwhelmed. And something that was very important, that every single referral we got to our service was admitted to our service, which means that we made sure that our waiting list was always empty, and we admitted every single patient who reached out to us. So this is in brief our experience with the telemedicine during COVID-19. And now I'll leave the floor to Rana Aid, who is gonna tell us her experience with Balsam. Thank you, Rana.
Thank you, Dr. Aline. Hello, everyone. I'm really happy that I'm able to share with you our experience with Balsam Lebanese Center, who was providing and is still providing the care for my dad. Well, to start with, my name is Rana Aid. I'm an interior architect. I'm from Lebanon, and I'm taking care of my father, who is a cancer patient. 2 years ago, he has been diagnosed with liver cancer, and he has been operated, and then he recovered. Unfortunately, a few months back, he had a relapse, and this time we couldn't do any surgery. His pain increased, and we needed to provide palliative care. So I've been introduced to Balsam Lebanese Center. I've checked their website, and I found out that this is the support and the service we need, especially at this time where Lebanon is facing economic and pandemic crisis. And we just needed to find the easy way to help Dad and ease his pain. So we contacted Balsam, and definitely we've been introduced to a nurse who would be following up with us on daily basis. And we definitely faced challenges, especially that it was during the pandemic and the lockdown. To start with the challenges, if we can move please to the next slide. So the first challenge was the lockdown restrictions. We weren't allowed to have home visits by the nurse. So we had to coordinate all symptoms, all diagnoses through WhatsApp or phone calls or video calls. So it was a big responsibility for me just to make sure that I'm really diagnosing well or checking the symptoms well, describing it well to the nurse, so she can as well be treating it the best way she can. The next challenge, it was a bit personal, and it was to introduce to my dad the idea of having such a service by phone. He couldn't accept the idea at the start, at the beginning, but later on, with the care he had, he regained trust a bit, and definitely video call was a must for him to meet the nurse and to see that he's been taken care by professionals. So at a certain time, it was important for me to meet the nurse, although it was very restricted, but I had to take a prescription to do an ultrasound. So we managed to meet outdoors under a lot of precautions. I met her at the entrance of her building. We kept social distance. We even wore masks, definitely. But when we saw each other, we just it was very weird not to be able to see our faces. So we just removed the masks for a second and introduced ourselves. But that gave me assurance that now I know who I'm dealing with, who I'm talking to every day. But this leads also to the next challenge, which was the lockdown restrictions. I needed to get the prescription and to provide the needed care for my dad. At the same time, I needed to follow the rules of the country, as Dr. Aline was sharing. So I had to manage to drive my car on a certain day so I can get the prescription. Although we faced these challenges, I'm going to talk about the facilities in such a time as well. If we can move to the next slide, please. So together, us and Balsam, we were facing these challenges, yet we experienced a new way of communication, and that was through telecommunication. Whenever we had symptoms, I had to describe it well. I even sometimes my dad had his legs swollen, so the nurse told me she's suspecting blood clots. She asked that I send her pictures of my dad's legs through the WhatsApp messages, and it was easy for her to guide me through. She ordered an ultrasound, and I managed as well to get the prescription like the time before. And whenever the results were out, I sent it to her by WhatsApp. It was a confirmed case of blood clots, so she was right. She offered a specific treatment with medicine through the phone. She just explained the side effects that might occur, so I can pay attention at home to everything, every symptom. And she followed up on a daily basis, monitoring all symptoms through phone calls. Also later on, Dad needed to be hospitalized. I contacted her and we communicated everything that's happening. We managed to contact a doctor and to be admitted to the hospital. The nurse helped with all the details just through phone call. And it was really a big help for me just to manage to take Dad to the hospital, and the nurse helped with all the other details. So that's a great facility. Just by phone call, we've been really supported at that time. The next facility is that we were at a certain point in need of a visit, especially that my dad had major symptoms and he needed more care. So with the fewer cases of coronaviruses in the country and with a bit of less restriction by the government, the nurse managed to pay us a visit. She took a lot of precaution and safety measures. When she arrived, she removed her shoes outside. She put on clean slippers. She washed her hands well and definitely wore a mask at all times. She met Dad finally. He was really happy that he saw her finally, and she examined him. And we talked through all symptoms and treatments and what to expect. And actually, this is, I guess, a good way just to, when you meet like with the nurse, or when she meets her patient and their caregivers, it makes it's more easy to just deal with whatever situation. So that was important as well. To conclude, just to say, while taking care of my dad facing this ugly disease and trying definitely to ease his pain, I found myself supported by a family of professionals, especially during such a crazy time of crisis. We are facing challenges definitely in providing the proper medical care. However, it is still practical and very efficient using phone calls and WhatsApp and every video calls we can do. So especially with the Wi-Fi at our Wi-Fi connection at our country, but we're managing well. we are both, I believe, us and Balsam team managing to overcome the obstacles during the lockdown. And we're using all possible ways to provide the needed care every day. I'm really honored that I'm sharing this with you today. And thank you, Balsam team, for your care. And thank you all participants for listening. Stay safe and healthy. Thank you.
Thank you, Rana, and thank you, Adeline. Thanks very much, Rana, for sharing your personal experience. It really helps to get your perspective on getting this kind of care. I'd like to remind all the audience to submit their questions in the chat box. And Kate has been reviewing the questions that have been coming in. So if we can start with the questions that have come in, Kate.
Thank you very much, Hiba, and thank you to all the panelists for really interesting presentations, and especially to Rana. It's amazing to hear about everything that you're doing for your dad, and to hear about the support that's been organized by Balsam in this very strange time. So yes, thank you very much to you and to everybody. The first question that's come in is, do the presenters have any suggestions for mechanisms to complete advanced directives virtually in the community?
Who would like to take that question? Maybe Louisa?
Yes, I can. Well, actually, what has been seen is that like building trust first at the beginning might be necessary, and specifically a private space, and be aware of the persons who are around, and having to introduce that discussion of advanced directive early in the clinical encounter, and having a clinical encounter specifically for advanced directives might be helpful. Although challenges are also posed as privacy is difficult to achieve in homes where everyone is around, or for example, they cannot be in a different space with their families. So it has been difficult. It has not been impossible, but I think that we have to migrate to a more standard process, and privacy might be an issue. And perhaps when you see that the minimal requirements are not being able to achieve at the virtuality, they might be necessary for a present consultation, a face-to-face encounter. But it's a difficult issue to achieve, as told in the presentation. Yes.
Yes, thank you, Louisa. And I'd like to add, in terms of what you addressed is how easy it is to obtain this, especially because you don't have the privacy and the intimacy of a face-to-face encounter. But there's also the how legal the documents are. If in settings where you usually have to sign documents, I know what we've been doing here in Boston is that the provider documents it in a note, and on the actual sheets, they can write a note where the patient's signature goes that states that this was done over the telephone. And these are exceptional circumstances, but they've allowed those documents to be legal.
May I just, sorry.
Yeah.
I was just thinking there was in the BMJ, Stephen Barclay, he had an article out a few weeks ago about reassessing advanced care planning in light of COVID-19, and he said that social distancing, remote consultations make it difficult. But I think the sort of two things that came out of that, the focus on the conversation, not the process, is key. That was one of the points. But the other thing, I guess, is also in this strange time, it also presents new opportunities around advanced care planning. So, for example, he talks about frail patients and the difficulties in terms of maybe bringing up that conversation about advanced care planning. But actually, in the context of COVID, it might be a more acceptable reason to discuss future care rather than diagnosis. It's kind of a universal threat that we have from the disease. So there's kind of the difficulties posed, but also I guess within COVID, we have opportunities as well, I guess.
Thank you, Matthew. Anybody else want to say anything about advanced directives before we move to the next question? Okay, next question, please, Kate.
Thank you. We've had two questions around the issues with legal provision of controlled substances while doing telemedicine. And could the presenters outline the steps to make e-prescriptions, especially for opioids, legally available?
Eve, can you share your experience? We've talked about that extensively. Can you hear me, Eve?
Yes, I can hear you.
Okay. Did you get the question?
I think, yes, I got the question, but I think it's Louisa who shared the experience of using digital technology to do opioid prescriptions.
Okay, Louisa, you want to take a stab at that question then?
Yeah, for sure. For example, well, here in Colombia, things have been more easy as a resolution was emitted by the national government that allows online prescription and also delivery at homes for controlled substances. I know that there are other countries that were not having these resolutions available, so limitations on prescribing and home delivery was a very important issue during this pandemic. But I think it must start with regulation at a government level, because as we all know, controlled substances need special precautions, but the government needs to be sensitive to what is happening right now. And part of the outcomes needed in palliative care, we need to have medicines available for everyone who needs it. So it's not consistency with what we wanted with telemedicine without having an e-prescription available. And regulations for e-prescription were mainly extrapolated what we're doing in the physical prescription. So it's exactly the same as a physical prescription here in Colombia. I don't know how other countries are managing, if they have other formats available. So here we have we have to send the patient 3 copies, and information is needed in the whole prescription, including your your office data, so they can call you and confirm that you have prescribed that medication.
Thanks, Louisa. Aline, do you have anything to add to Louisa's intervention?
Not really. We also had to provide the prescription, and we were meeting patients whenever they can drive and have access to us to stamp the prescriptions and take it to the ministry. So the same procedures applied. The rule I talked about sending the prescription by WhatsApp did not apply to opioids.
Yeah. Okay, thank you. Next question, Kate.
Thank you. We've also had a number of questions about the financing of telemedicine. Obviously, it involves human resources and other infrastructure costs. So there's 2 parts to this question. The first one is, how do you charge for each telemedicine session? And the next part is, are there any funding models for this approach, and how is it integrated in national public health funding systems?
Okay, who wants to take a stab at that one?
I could take a start. I could go first. Most African countries are already embracing technology and some of these applications, and most of them are actually open source. So within the health service or delivery system, technology is already catered for as part of the upstream costs. And then NGOs and hospices and community-based care services, need to invest more in the use of technology to promote the use of telemedicine in palliative care. And of course, we are leveraging on the use of telephones, making phone calls. That is a very useful intervention. And at times, the healthcare workers face the burden of having to meet the costs associated with making calls to patients and families. And also on the side of the patients, they have to deal with the catastrophic expenses. So going forward, health systems should look at innovative ways of trying to absorb some of those costs, like toll-free lines could be provided as an intervention in palliative care, just like it's being done in other sectors.
Okay. Any thoughts on this, Louisa and Aline?
Well, actually, I think telemedicine needs to be incorporated into all healthcare plans. And reimbursement must be an important issue that might have to be incorporated in the regulation. And well, here in Colombia, we have a social health system, so telemedicine is part of the benefits already in the system that help us broaden the capacity to people, but I think that this pandemic made telemedicine to be looked as a private services and not like a social health system service. So it needs to be included in the health systems properly under regulated forms.
Okay, thank you. Aline?
Yeah, I agree with Eve and Louisa. There's not much to add. Since our experience at Balsam, we provided free of service, so we did not struggle with that part at least. But definitely, I think we know that the telemedicine is here to stay, and most of the people are going into these tools in medicine. So eventually, all the healthcare worker, and it should be worked at the policies level. But we haven't started the ground for that in our country yet.
Yeah, I think we can all say that this all grew very quickly, and so we don't have the framework for reimbursement. We don't have the framework for also the medical legal aspects and documentation, as Louisa was saying, and so those will have to grow out of that. But I think policymakers are already seeing that this is something that will need to be integrated into health systems. Matthew, do you have anything to add?
Something to add a bit. And we have to be sure that reimbursement is an issue, because if reimbursement is not part of the health plans, telemedicine will not be sustainable in a long time. So for sustainability, reimbursement must be incorporated.
Absolutely. Matthew, you have thoughts on this?
Yeah, I guess it's also how telemedicine is perceived and what it delivers. So, for example, I think one of the barriers in the US at the moment, particularly for providers, is that they might be reimbursed at a lower rate for a telemedicine consultation than they would be for an in-person consultation, even though, you know, they might be delivering they might have the same conversations, make the same decisions. So I guess there's a longer term way about thinking about how telemedicine is perceived and what it provides. And maybe there's an issue that we don't yet have good enough evidence to demonstrate that telemedicine approaches can lead to, you know, and the same outcomes, and maybe they don't, you know. So I think there aren't clear models, but it's not going to be straightforward developing them either.
All right, thank you. Kate, next question.
Thank you. So the next question is around diagnosis and how to give a diagnosis over the telephone. The example that the delegate gave is a 57-year-old advanced breast cancer with chief complaint of dyspnea. How can telemedicine help us to differentiate from pleural effusion, pulmonary embolism, or COVID-19?
Okay, how about Aline?
It's not easy actually to differentiate. And one thing that's very important that our study has reflected that the level of experience of the physician or the nurse is very important when we talk about telemedicine. And we had this challenge whenever we have nurses that has just started with us. The level of comfort was way different than nurses who had experience of 5 years and 10 years. And even physicians, it's not easy for anyone. Like it needs to, like experience is needed to be able to tell. For this specific question in particular, it's not that easy to tell. So we will rely on the saturation of the oxygen on the pulse oximeter that can show us. The PE, the patient might not be short of breath completely. We try to see the crackles. Sometimes, you know, one time we had to teach one of our family members to use the stethoscope. So we had to send them sounds about what is a crackle or what is something. And you would be surprised how much family member can help you. And they tell you, no, I don't hear anything on this side, for example. You know, but it's not easy to make a diagnosis. That's why I mentioned the challenge when many times we need to order a chest x-ray. And we had the challenge to see who would accept and go do the chest x-ray. So the answer is not straightforward.
Yeah, I think in terms of this, one, what you just mentioned, Aline, we found that when family members are given tasks, especially technical tasks, when they can play a role, they actually really appreciate it and feel very useful and that they're doing something for their loved one. So that's one thing. But the other thing is also the goals of care of the patient will drive you to decide how important it is to know whether this is a pleural effusion or a PE or something else and how to manage. And if the goals are still to get active treatment, the inclination to send a patient to the emergency room or the hospital will be much higher. Any thoughts, Louisa, on this?
Yeah, this is probably an example of the utility, for example, of artificial intelligence. And this, just to mention the opportunity that is indeed for the incorporation of ultrasound, for example, to assist on accurate diagnosis. But this is a field that needs to be constructed, and let's see what the future brings.
Anybody else on the panel before we move to the next question? Okay, next question, please, Kate.
Thanks very much. Could any of the panelists comment on supporting children with serious underlying health conditions via telemedicine and the specific challenges in providing this kind of care?
All right. I don't know who's the most appropriate for this one. Who wants to go for that?
I can share our experience at Balsam. We had few patients that we took care of, and like I said before, the level of experience and how comfortable the healthcare professional is. So we were lucky to have a physician with us who took care of one of the patients. And you know, most of the time we rely on the mother or the caregiver at home in order to be able to assess the best. And we work in very close coordination with the Children's Cancer Center. It happened that we had few patients with cancer, so we always coordinate with the cancer center, and we were able to manage. It's like any patients, video calls were the most important, or sometimes the family would take the videos and send us the data.
Anybody else for this question? All right.
Yeah,
go ahead, Eve.
I would add on the piece around the use of telephones, most especially to speak to adolescents about their symptoms and other multidimensional concerns, and that can inform the prioritization of care.
Should I add something as well? It's Julia here from the International Children's Palliative Care Network. Just to say that some of our experience is that many children are actually more used to using iPads, using phones, etc. They're chatting to their friends. They're quite used and quite familiar to using using systems like this. And so our experience with the telemedicine has been that for many of them, they're actually more comfortable than some of their parents and some of the adults. But obviously it depends on the child, and you need to be very careful and sensitive to that.
Interesting. Thank you, Julia. We have time for one more question, Kate.
Thanks very much. The last question is, in the panelists' opinion, can telemedicine reduce mortality?
Our data people, Eve or Matthew?
I would say yes, because it gives us an opportunity to do comprehensive symptom assessment and act early enough. But of course, robust evidence is needed to demonstrate that outcome.
Matthew, anything to add?
Yeah, I guess same position as Eve. I guess where we stand in terms of palliative care for telemedicine, there's a lack of evaluation and really robust study design. So there's not the evidence for that yet. It's a possibility. But if you know, we are to explore this, it's understanding not just whether it does, but how it does, why it does, when it does. You know, so there's lots of elements to that that we don't know answers to yet.
Thank you. Very good.
There are several trials, and Matthew, you probably know this better than me, but there are several trials going on around the use of telemedicine in palliative care. There's a big one in Europe, which is MyPal, which is looking at telemedicine in adults, and also utilising games and things like that in children, and integrating patient-reported outcome measures. So I think there are various different types of trials ongoing at the moment. So we await the answers.
Any of them looking at actual mortality or other outcomes?
I don't know how many of them are actually looking at mortality. I know a lot of them are looking at other outcomes, but I think certainly in some of them, mortality would be a secondary outcome that they'd be looking at.
Yeah,
that's a hard one to measure, isn't it?
It is. Thank you. Thank you, everyone. Thank you for the great questions, and for the panelists for your answers as well. It's time to close, so please join us for next week's webinar. That's next Thursday, same time, the 25th of June. And Julia, would you mind telling us a little bit about what's planned for next week?
Okay, yep, that's great. So next week we're going to be looking specifically around palliative nursing. So the webinar is going to be valuing and strengthening palliative nursing in the time of COVID-19. And we're going to hear from people from Ireland, from a colleague in China, from a colleague in Brazil, and a colleague in Uganda. So it should be an interesting session. So please do join us.
Thanks, Julia. And thank you for everyone, to everyone for joining us today. We hope you'll join us for future webinars. And I also encourage you to visit the globalpalliativecare.org website to view previously recorded webinars, and also look at our briefing notes. And thank you to our panelists, Eve, Matthew, Luisa, Aline, and Rena, and also to Gabriela and Nicholas, who contributed to our presentations today. Thanks so much.
Thanks, everyone.
Thank you.